Okay, so this is a case of a 57-year-old man, has a history of hypertension, type 2 diabetes, and obesity. He presents to a hospital with fever and back pain, is admitted to hospital under the medicine service, and subsequently is found to be bacteremic with strep mitis. MRI was done and had L4-5 osteomyelitis discitis diagnosed. He was initially managed with IV antibiotics, and they didn't think there was an abscess there, but he wasn't really getting better, and after kind of lots of discussions with the orthopedic surgeons, they took him to the operating room, and they didn't find any abscess. They found a lot of inflammation, and they ended up doing a decompression. And after the surgery, he really didn't get any better. He was still kind of just languishing and troubled by a lot of delirium and just generally not doing well, having fevers despite having persistently negative blood cultures while on IV antibiotics. And so an echo was done to exclude endocarditis. So I'll just give you a couple pictures from his echo to look at. There's an abnormality somewhere within these images, right? Or it wouldn't be a near miss. Okay. All right. Maybe you see it, maybe not. All right. So, the report said that technically difficult study, right? This was not a cherry-picked case. These were tough images on a patient with a large body habitus, but no definite cardiac valvular vegetations were identified, okay? Continuing on the same course, ongoing delirium, lack of improvement, negative antibiotics, negative cultures while on antibiotics, and after a number of days go by, ID was reconsulted. They were kind of consulted in the beginning and signed off, and now they're back, and they recommend do a TEE. And so there's his TEE. So the first thing we're struck by, which we didn't know before, is that he's got a bicuspid aortic valve, okay? And then if you look kind of just posterior to the aortic valve, you see that echolucent space. And that is an abscess. I actually didn't have a great picture of it in the long axis view, but it was pretty convincing for an abscess. He did go on to get a CT. I don't have that picture for you, but it shows much the same thing. Okay? So here was the view that from the TTE, where if you had a really discerning eye, you may have been able to see it just posterior to the aortic root there, that small abscess cavity. Okay, very easy to miss. It was missed on the first TTE. So cardiac surgery was consulted. He agreed after some discussion that he should go to the operating room to get this fixed up. There was concern about taking him too soon after his back surgery and the risk of bleeding. And so actually more than 2 weeks ended up going by. And by the time he got to the OR, when they put the probe down in the intraoperative TEE, there was a bulky vegetation on the aortic valve, which wasn't there before. Actually, the OR report said that both of the cusps had vegetations, but this guy over here was not there a couple weeks earlier, so this was kind of progressive endocarditis, and it's good that this patient went to the operating room when he did. And he ended up doing fine. He was on antibiotics, obviously, for a prolonged course, and his back pain took a while to settle down, but in the end, he did well. So, a couple take-home points, easy to remember from this case. First one is go with your gut, and that's for the clinicians. We're all clinicians here, and so in a case where you have a patient who you think is infected, not getting better, who you're suspicious of endocarditis, and the initial imaging doesn't really help, doesn't show anything, try and try again, try other imaging modalities. I'll show you a couple recommendations from the guidelines with respect to that in just a minute. But if you're persistent, you may just save the patient's life. The other one is more from the EchoLab perspective, which is know the clinical context. So when I'm reading studies in the lab for this indication with our fellows or our trainees, I don't quiz them necessarily on the echo. I quiz them on the clinical context. What did the blood cultures show? What did the repeat blood cultures show? Is the patient on oral or IV antibiotics? What do the other investigations show? And most importantly, is the patient getting any better? You know, most of these patients are admitted to hospital, and so that information is readily available, and we really need to know what it is in order to guide subsequent investigations of this patient. I think one of the challenges with this echo report was not so much that that abscess was missed, which was very easy to do, but that a TEE wasn't recommended based on the challenging pictures and the case and the clinical context of this patient. So those were a couple take-home messages from this case. Just a little bit of background, I think I have some more time, on imaging in patients with infective endocarditis. And these points are taken from the European guidelines, which are also very excellent and were released in 2015. Echo is first-line imaging evaluation for suspected infective endocarditis. I think we all can acknowledge that. TEE is indicated when TTE is negative and there remains a high clinical suspicion, or the TTE is of suboptimal quality. And in fact, if the TEE is negative and there remains a high index of suspicion, then doing a TEE within a week is recommended. You know, and sometimes we will groan about this in the echo lab. Oh, they just had a TEE. Come on, you really want another TEE? Well, if they're that concerned about it, then it's in fact warranted. A couple interesting numbers with regards to the sensitivity. So when it comes to vegetations, TTE is actually pretty good. It's over 70% when you kind of pool all the studies together for native valve endocarditis, and obviously much less for prosthetic valve endocarditis, 50%, which rises up to 90–95% for TEE. But when it comes to detecting an abscess, TTE is actually much, much worse. It's less than 50%, and I suspect significantly so. TEE, of course, is better, but TTE, when we're talking about finding an abscess as opposed to a vegetation, can be quite limited. And of course, when it comes to prosthetic valve endocarditis, TTE can be very challenging. We don't see everything we wish we could see, and often there's paravalvular extension, which TEE or other imaging modalities are better at imaging, and we see kind of paravalvular complications such as regurgitation present. So what are those other imaging modalities that are useful? Equivalent and may in fact be superior to echo for defining paravalvular extension of infective endocarditis, especially for prosthetic valve endocarditis. And nuclear imaging over the last several years has become a very important tool if it's available to you for imaging these patients, and does add incremental value, particularly for prosthetic valve endocarditis. And there are two main modalities. One is a white blood cell scan using SPECT-CT, which has very good specificity for infection because you're tagging white cells, but the spatial resolution isn't quite as good as CT or even TEE. And the other, which might be more commonly available in some centers, is FDG-PET. Very sensitive for inflammation, but because you're detecting inflammation, may be less specific, particularly in cases such as when they've just had cardiac surgery, and there's lots of inflammation that's healing all over the place. The other nice thing about FDG-PET is that it offers potentially whole body imaging, and so you can also scan for septic emboli while you're scanning for infective endocarditis. So here's just an example that I found in the literature. I picked actually a case. This is a patient who has previous ascending aortic graft replacement and an infected tube graft, okay, with no evidence of vegetations on their echo, including their TEE. So that can be a very difficult infection to detect by our standard imaging. The CT scan here actually showed subtle signs of that, but when they did a PET scan, and this patient also, a PET scan and a SPECT scan, you see that aortic graft lights up quite nicely, and that helped confirm the diagnosis. So especially when there's prosthetic material, think about some of these other imaging modalities if the diagnosis remains elusive and the patient's not doing well. So here's the diagnostic algorithm that was published in the European guidelines back in 2015. For these cases of, now we still use the Duke criteria, although it's been modified and modernized. And for these cases that are more suspicious as opposed to confirmed or excluded, if it's a native valve, your next step after you've done an echo is to repeat that echo if there's still clinical suspicion, and then you move on to different imaging modalities, such as looking for embolic complications if those are suspected, or CT. Whereas for suspected prosthetic valve endocarditis, again, you'll repeat the echo, repeat the TEE if you need to, and if still you're worried about it but it's not being found, then typically you move on to nuclear imaging as your next modality, and CT or imaging of embolic events if those are identified or suspected. Okay. So, in summary, infective endocarditis presenting as isolated paravalvular or aortic root abscess without significant vegetations identified by imaging can be very difficult to identify by echo, even by TEE in some cases. Clinical suspicion should always guide your imaging and diagnostic strategy. Echo is first line, and there should be a low threshold for doing TEE at all times if there's clinical suspicion. And as mentioned, even repeating it next week if the patient continues to not do well, or bringing in other imaging modalities if needed. And here are a couple good references. So here's the European guidelines, and that's from 2015. And also there was an excellent review published last year in JACC on some of the modern challenges of detecting and treating infective endocarditis. Okay, well, thank you very much. Appreciate your attention.